Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everyone. First of all, I apologize for the slight delay in the starting of the session. I welcome you all to the Chemical Pathology Scientific Session in ICON 2022. I am Dr. Fatima Kanani, Section Head Chemical Pathology at the Indus Hospital, Karachi. The theme of today's session is Laboratory Medicine, Advancing the Quality in Critical Care. We will be talking about different dimensions of how the laboratory can play its role in improving the critical care services. We are lucky to have some of the very renowned chemical pathologists in this session, as well as our colleagues from the emergency department. We will be initially sharing with you 5 pre-recorded talks from our esteemed speakers, and we will then have a live question and answer session in which you can get answers to your queries. And just for clarification, please do not forget to fill out the feedback form at the end of the session, because without the feedback form, you will not be able to get your e-certificates. So without wasting time, let us move forward with our session. I will be delivering the first talk on turnaround times, and the title of my talk is Turnaround Times, When Does the Clock Start Ticking? A discussion on benchmarks.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everyone, and welcome to the scientific session of chemical pathology. I am going to talk to you about the turnaround times of critical tests in the lab. And the title of my presentation is Turnaround Times, When Does the Clock Start Ticking? A discussion on the benchmarks. My talk is not going to contain any hardcore technical material. Rather, the aim is to focus on sensitizing our laboratory colleagues on the importance of this vital ingredient of critical care testing. I have no disclosures to make. My talk is going to focus around these concepts. We're going to talk about quality. Why is turnaround time important? Benefit of TAT, definition and metrics, how to shorten TAT, and a little bit about the Indus story. So quality is defined as the ability of a product or a service to satisfy the needs and expectations of the customer. For the laboratory, our customers are our patients or doctors and nurses. But the ultimate beneficiary is the patient. When labs talk about quality, their focus is mainly on the analytical component. That is, they focus more on accuracy and precision. However, for the doctors, the most important part is the service component. That is, they are more interested in a rapid, reliable, and efficient laboratory service. And timeliness is perhaps the most important factor for them. And this is the main reason why POCTs or point of care testing has mushroomed up recently. Where and why is POCT applicable will be discussed in another talk in this session. So why is monitoring TAT important? Why is it so important for us to see that the tests are reported within a certain time period? TAT is a key performance indicator of the lab services. And as I mentioned, many doctors judge the quality of a lab by its turnaround time. If the results are not received by the physician soon enough for them to initiate a timely treatment for the patient, then the point is there's no point of the late result. So the delay in lab results is a major source of complaints to the lab. And what are the benefits of controlling the TAT? Of course, it increases the credibility and satisfaction from the patients, doctors, and our customers. It ensures the timely patient management, and this translates into faster turnover of the beds, because the sooner you release the results, the sooner the clinician can manage the patients and there is possibility of taking over the next one. And this is beneficial for both commercial and non-commercial labs. So let me begin by taking your view on the fact that what do you think is the best time to start monitoring of TAT? How will you define the turnaround time? Is it from test ordering to the reporting? Or is it from sample collection to reporting, from sample receiving in the lab to the reporting? Or do you think the definition is institution dependent? If this was a live session, I would have taken a show of hands or conducted a poll. However, you can jot down what you think is the best response to this, and then we will see. So turnaround time, just like when we discussed the lab errors, has a pre-analytical, analytical, and post-analytical component. The pre-analytical component starts from the clinician's order and involves the sample collection and transport to the lab. Then component from the sample receiving and analysis in the lab is the analytical component. And then the result transmission to the clinician for the action is the post-analytical component. The problem is that the part of the turnaround time from the receiving of the sample till the result releasing is very much in control of the lab, and the turnaround times are easily extractable for these components. However, the initial part, that is from the order and then the collection and the transport, is more often in the domain of a separate group of people. And the times are also not very easily extractable. Often labs fail to take ownership of this component of the total turnaround time. However, the fact is that when the patient comes to the laboratory, the most important aspect is how soon we can manage that patient. And for this, the whole testing process, the total testing process has to be considered. And the lab has to take ownership of the entire process, no matter what interactions it has to do with the other healthcare partners. So the TAT measurement, TAT can be classified by the tests which we are doing. That means it could be test-based. It could be dependent on the location or the origin, for example, the IPD, OPD, or ER, or it could be based on the priority, whether it's urgent, routine, or a batch test. So we need to have a clear definition of the parameters we are going to measure, because the same test can have a different turnaround time if it's from the ER or from the OPD. And usually it is the median or the 90% or 95% completion time and the delay rates, which are the preferred metrics. Mean and SDs are not preferred for TAT measurement because each component of the TAT has a minimum time below which you cannot go. For example, if a centrifuge has been set to, say, 10 minutes spinning time, then it can exceed those 10 minutes if there are errors, but it cannot go less than 10 minutes. Similarly, if the incubation time of a test is 5 minutes, then we cannot go below that. So mean and SDs are not very reliable indicators. We would rather go over the shortest completion time at 90% or 95% or the median. One concept for the total turnaround time is a brain-to-brain concept. Lundberg is a medical scientist who has put forward this concept around 40 years ago about the brain-to-brain loop for the lab tests. It includes pre-analytical, analytical, and post-analytical components. As you can see, the various components are shortlisted here. When you're talking about the emergency department, there are various ways in which we can reduce the TAT. You can have STAT testing in the central laboratory. You could have a satellite laboratory in the emergency department, or there could be a point of care testing facility available. Each institute has to decide what suits its purpose and for which tests. The aim is to get the reporting done as soon as possible. This is a scenario in which, in the first part, we can see that when the patient comes to the triage, his ECG is done and the patient is shifted to the ED room, where the physician sees the patient and suspects a cardiac disorder, orders troponin, and the nurse draws the patient. The time from the patient entering the ED to the test order is 54 minutes in this scenario. However, if we make this process lean, then at the triage, ECG can be done and the nurse orders the troponin and the blood is drawn. By the time the patient is seen in the ED, the test has already been ordered and the time from the patient entering till the order is 11 minutes. So this is how the one component can be shortened. Let's see another case study. For example, a 47-year-old man, non-diabetic, non-hypertensive, starts to feel chest discomfort at 9 a.m. in the morning. He attributes it to a gastric problem related to his late dinner, lays it down. When it worsens, the family calls for an ambulance to take him to the tertiary care hospital. At 10:30 a.m., the patient reaches the ED. So 9 a.m., he develops the chest pain. 10:30, he's brought to the ER. And at 10:45, he's seen by the doctor and the lab tests are ordered. 11 a.m. sample is collected. 11:15, sample is received in the lab. And within 50 minutes, that is at 12:05 p.m., the test results are released. It takes 10 minutes for the doctor to see the results and shift the patient to the cath lab. Now, in this scenario, if you see, the overall TAT is 90 minutes. Pre-analytical TAT is 30 minutes from the order to sample receiving. Analytical TAT is 50 minutes, that is from receiving the sample to the result. And the post-analytical TAT is 10 minutes, that is results releasing to the action. If we were to reduce the turnaround time in the lab to 60 minutes, the patient would be able to receive the management earlier. So what are the components? How can we reduce the three components of TAT? The pre-analytical TAT reduction can be reduced by a barcode labeling of the sample. If you have a designated traceable sample transport system, you have a designated sample receiving area, you have a sample identifier for the stat samples so that the technologists know that these are the stat samples which have to be prioritized. For example, you could have a color-coded caps, color-coded stickers. Lithium heparin tube safe plotting time. Staff should be sensitized that this is a top priority to process these stat samples. You could have a separate stat pathway, for example, a separate centrifuges for this purpose and urgent processing track. And if the pre-analyticals are automated, this would save time even further. Now, analytical component, your instrument selection should be such that there are least possible downtimes. Your assays are good quality. There is proper maintenance and service of your instrumentation. Your processes are automated. For example, the dilutions, your water supply, water and power and water supply connectivity issues are streamlined. In the post-analytical component, most important thing is to have a robust IT system, interfacing of your lab results, a lean workflow, electronic transmission of results, and one important component is auto-verification, which would reduce the turnaround time remarkably. How will you measure the TAT for your tests? First of all, you have to categorize your tests, whether they are routine, special, batch, whatever. Then considering the time you would take for a particular test based on its priority, we must create a list and mention the turnaround time for those tests. We set an expected TAT, according to the benchmarks and the priority of that test type. We monitor the test according to its expected TAT and considering the fact that the same test can have different TATs based on different locations. The benchmarks have to be modest in the beginning. We monitor, do a root cause analysis, come up with the corrective actions, and then implement the interventions, then gradually raise the bar. So what are the different benchmarks which we can consider for defining our TAT? RC Pat, Royal College of Pathologists, in his document Kpi Proposals for Implementation, published in 2013, included a target turnaround time of 1 hour from receipt of 90% of the core tests for an emergency department. These tests included were liver function tests, urea, electrolytes, troponin, and CBC. From April 2015, this was changed to 1 hour from sample collection rather than receipt by the laboratory. So still 1 hour, but the starting point has changed from sample receiving to sample collection. And beyond this, it was recognized that different individual pathways would require different TATs. So this is Royal College of Pathologists. Now, Association of Clinical Biochemistry did a survey in which forms were sent out to 173 heads of laboratories of UK labs listed in ACB database. And this was published in Annals of Clinical Biochemistry 2017. There were 100 responses. The participants were asked about the acceptable and unacceptable turnaround times. And the consensus was that for the emergency department, STAT test should be less than 1 hour TAT, and the TATs of more than 2 hours were considered very high risk for patient safety. If you keep the TAT at 1 hour, then for the total testing process, the target for the lab TAT would be around 40 minutes. So this was their response. The ED department, for the ED department, 81% said that the TAT should be less than 1 hour, and most of them said that 2 hours would be unacceptable, would be very high. And for the wards, less than 4 hours was an acceptable response, while more than 12 hours was unacceptable. And for the OPDs, 24 hours was ideal. What about CAP? 1998 Q probes suggested the 90th percentile completion time of potassium and hemoglobin TATs. As if you can see in the slide, 75th percentile of the labs suggested that from the order to the reporting, the total turnaround time was 57 minutes. So that is less than 1 hour. From order to reporting, the TAT of the total testing process should be less than an hour. And this would again come to a laboratory test, an analytical TAT of 37 minutes from receipt to reporting. So this is what we should aim for. We can't go to the targets which have been set by the 90th percentile, but at least we can try and achieve the target set by 75th percentile of the labs. And remember, this is 1998 Q probes. So do not panic. These are the benchmarks which have been set internationally, and we should strive to achieve them. Be patient-centered, There's a need to broaden your horizon, think of the loftier goals. The end point is better patient outcome. We should not pine on our restrictions, on our limitations. We should focus on what is timely for the patients and try and find the solutions to that. Let me talk about the Indus story. It's not that we have achieved this goal, but the point is that we are trying and trying relentlessly. So far, we have bedside barcoding of samples, we have interfacing, we have electronic report delivery, we have automation. We have a separate call center to inform the critical lab results. Our laboratory technologists do not have to wait to inform the results before releasing the test. We have a separate call center for that. Most of these things are also available in with most of you. When we installed total lab automation, quite a few of our processes were manual. The samples were received in the lab, they were entered in registers. We had to take out the barcode labels for them in the lab. They were taken manually to the centrifuges. There were centrifuge, the technologists would take them to the various analyzers. And then after the results would come out, if they needed rechecking, the sample would be again sorted out and rerun and then reported and archived physically. So this was a time-consuming process. We then installed total lab automation in September 2018. And before and during this time, we tried to make our processes more lean. And we had this bedside barcode labeling, interfacing, electronic transmission of results was already there. We had automated pre and post analyticals. So then with the installation of TLA, the manual step was actually receiving the sample electronically into the software. And then the samples would automatically go through the centrifuges, pre-analyticals to the various instruments placed on the track. If they needed to be taken to another instrument outside of the track, that was done manually. Otherwise, the processes went smoothly from one step to the other. If there was a rerun required or a critical result, they were automatically sent for the rerun and the results were transmitted. The samples were stored in the storage module to be later retrieved. What happened with this TLA implementation? We're talking about 2018. September 2018 is where we installed the total lab automation. Here you can see that our turnaround times drastically increased, and the percentage delays increased to up to 14% with the installation of TLA. This was because the staff was not acclimatized to this process, and this was the shifting over phase in which both systems were running in parallel. So there was a sudden increase in the delays, which gradually reduced to the pre-TLA percentages. Then there was another drop in exactly a year later, where we had a dedicated QA or quality assurance section set up in the lab for monitoring of all the KPIs. And here we had a sudden sharp decrease in our tabs. And this is our current data over this last 1 year, September 20 to September 21. And this shows the 90% completion time. Here you can see we are hovering between 42 and 48%, 42 and 48 minutes for the 90% completion time. Our aim is to reduce this to 40 minutes. We are not there yet, but we are trying, we are hopeful. What are the gaps which we have identified? There could be lags in data transmission. At times, the staff distribution might not be ideal. Staff has to be repeatedly sensitized. There could be instrumental issues, downtimes. If there's a breakage in the quality of water or power, that can lead to delays. So my last and final take-home slide is that the stat turnaround time should be less than 1 hour. And this should incorporate the entire testing process, that is pre-analyticals, analyticals, and post-analyticals. This is the standard of care and period. So this is just a cartoon saying the lab report has just come in time, so the lab is in fine shape. Thank you.
Thank you very much for bearing with me. And just to add on, we have now finally managed to achieve the benchmark of 40 minutes TAT. So without wasting much time, let me go on to the next speaker. Our next speaker is Dr. Mohammad Zubair. He is consultant chemical pathologist from Multan Institute of Kidney Disease, which is part of the Indus Hospital and Health Network. And all our chemical pathology trainees know him very well. Because he continues to share excellent, brilliant reading material for all of us. So Dr. Zubair will be speaking on pre-analyticals, and the title of his talk is "The Report is Only as Good as the Specimen: Impact of Pre-Analyticals in Critical Care." Dr. Zubair.
My name is Dr. Zubair, and I am consultant chemical pathologist at MIKD. Before starting my presentation, I would like to thank Dr. Fatima Kanani and Dr. Adnan Zubairi कि उन्होंने मुझे opportunity दी for this presentation at ICON 2022. The topic of my presentation is the report is as good as specimen and impact of pre-analytical errors in critical care. The learning objective of my presentation is the listing of the different pre-analytical variables which we commonly encounter in laboratory medicine, identification of nature and frequency of these pre-analytical factors which are responsible for sample rejection, how we record the errors in laboratory, then what are the different quality indicators and their utilization in lab processes, and different effective strategies to reduce the rate of specimen rejection and mitigate the risk of patient harm. First of all, what is a laboratory error? A laboratory error is actually a failure of planned action to be completed as intended, or use of a wrong plan to achieve an aim occurring at any part of the laboratory cycle, from ordering examination to reporting of results and appropriately interpreting and reacting to them. Previously, in previous decades, the labs are only focused on the analytical errors. But with the passage of time in 1990s and early 2000s, our focus was on the pre-analytical and post-analytical phase errors. And now at today, we are mainly focused on the testing-related diagnostic errors. Why we are interested in testing-related diagnostic errors? Because 60 to 70% of our clinical decisions are based on the laboratory test. As you know, अब हम हर जगह पे क्वालिटी की बात करते हैं in our different field. So similarly, there is a quality in laboratory medicine, and it can be defined as the guarantee that each and every step in the total testing process is correctly performed, and thus assuring the valuable medical decision making and effective patient care. The total testing process actually starts from the patient and it ends at the patient, and it has different phases like pre-analytical phase, pre-analytical phase, analytical phase, post-analytical phase, and post-analytical phase. These are the different components of the total testing process. Then there are different error rates in these total testing processes. As you can see, the pre-analytical phase has the highest number of the error rates, which is 62 to 76%. And then comes the post-analytical phase, which has 18 to 30%, and come the analytical phase, which has 6 to 15% of the error rate. क्योंकि डिफरेंट स्टडीज है और उनके अंदर डिफरेंट जो एरर रेट्स के जो परसेंटेजेस आई हैं उसके अंदर यही देखा गया है कि जो सबसे ज्यादा कॉमन एरर वाली फेज है दैट इज द प्री एनालिटिकल एरर फेज। इसकी वजह क्या है? क्योंकि इसके अंदर देयर आर डिफरेंट स्टेप्स एंड डिफरेंट पीपल्स आर इन्वॉल्व, दैट्स व्हाई एंड इट हैज द मोर एरर्स एज कंपेयर टू अदर फेजेस। लेकिन प्रीवियसली इन प्रीवियस डेकेड्स there are more errors in the analytical phase जब instrumentation इतनी ज़्यादा develop नहीं थी। Pre-analytical phase, it is defined as according to ISO 15189, the steps which are started in chronological order from the clinician request and including the examination requisition, preparation of the patient, collection of the primary sample and transportation to and within the laboratory, and ending when the analytical examination procedure begins. This is the definition of the pre-analytical phase. Then come the most common pre-analytical errors. The most common reported types of pre-analytical errors are the hemolysis, clotted specimen and insufficient specimens, missing samples and or test requests, wrong or missing identification, contamination from the infusion route, inappropriate container, inappropriate blood to anticoagulation ratio, and inappropriate transport and storage condition. These are the most common pre-analytical errors. The pre-analytical errors actually create the bottlenecks, means it will delay the results and it will lead to the patient redraw of the specimen, and it will also lead to the manual treatment of the specimen to get the desired results. The most common problems are the specimen integrity issues and quantity not sufficient, and these specimen integrity issues can be detected by the automated serum indices which are present in the different laboratory analyzers, and quantity not sufficient can be detected by the modular p-analyticals or analytics. This is the pre-analytical data of Multan Institute of Kidney Diseases. As you can see, I am just focusing on the emergency department, and it has the highest number of the pre-analytical errors from January to August, that is 108 as compared to other departments. And similarly, this is the pre-analytical data of the RTEH, and you can see the ER department has the highest number of the pre-analytical errors as compared to other departments. These are segregated, these errors are segregated into different reasons for recollections at the emergency department. And you can see the hemolysis is the number one cause of this recollection at the emergency department. And it is 38.2% of the emergency department recollections. Then come the clotted specimens, then come the QNS, and fourth one is the test not requested, and fifth one is the specimen contamination. But the major cause of recollection rates at the emergency department of the MIKD as well as or the RTEH is the hemolysis as well as clotted specimens. What is a hemolysis? Hemolysis is the most common pre-analytical variable, and it can be defined as the rupturing of the RBCs and the release of their contents into the surrounding fluids. And hemolysis can be in vivo or in vitro, and it interferes with the chemical testing of the different tests. How much this free hemoglobin cause an interference? It depends on the test as well as on the laboratory policies and procedures. So it is different for different test hemolysis, and as well as some labs release results with the comments, and some labs desire to recollect the specimen on the basis of hemolysis. How we can detect the hemolysis in our lab? Previously, we can just look at the specimen and we see the hemolysis, but now there are some features of like automated serum indices which are incorporated into the machines, and they are automatically detect the hemolysis lipemic and ecteric index. and it is very objective way to detect the interferences as compared to the visual inspection which we are using in the past. And it is actually a standardized and reproducible tool. Previously क्योंकि एक बंदा किसी और तरीके से उसको इंस्पेक्ट कर रहा है हेमोलिसिस को, तो वहाँ पे डिस्क्रिपेंसी के जो कॉजेज थे वो ज्यादा थे एज कंपेयर्ड टू दिस ऑटोमेटेड सीरम इंडिसेस which is objective way. But there are the limitations of this HIL index on automated analyzer because hemolysis and icteric give the spectral interferences, क्योंकि जो वेवलेंथ है इन फोटोमेट्रिक एनालिसिस वहाँ पे ये इंटरफेरेंसेस जो हैं वो कॉज करती हैं लाइक हीमोग्लोबिन एज वेल एज द बिलिरुबिन. And similarly the lipemic samples cause the light scattering, and it will also disturb the samples which has detection by light scattering phenomena. So इसकी भी limitations हैं HAL index की भी. Hemolysis index is assessed by the amount of red pigmentation associated with free hemoglobin. As you can see इस picture के अंदर आप देख सकते हैं कि plus 2 plus 3 and plus 4. तो उसके साथ उसका जो कलर है वो चेंज हो रहा है with the level of amount of red pigmentation. Then we are categorized the Hill indices with grading, and you can see there are different grades on the basis of the amount of the hemoglobin, bilirubin, and lipids. And the grading are, as you can see on the zero grading, there is less than 9 milligram of per dl of hemoglobin, plus 1 per 10 to 199, and plus 2 per 200 to 299. So these are different categorization of the Hill indices with on the basis of their content. और ये मशीन्स के अंदर इनबिल्ट है और वो किसी को डिटेक्ट कर लेते हैं और उसके बाद आपकी मैन्युफैक्चर की गाइडलाइन होती है कि आपने इसको आगे कैसे प्रोसेस करना है स्पेसिमेन को. The analytes which are affected by hemolysis are following, like they have positive interference के उनकी जो value होगी that will increase. Some analytes are decreased by hemolysis and some have positive or negative interference. The positive interference by hemolysis जो analytes हैं उनके अंदर potassium, magnesium and phosphate है, lactate dehydrogenase है और aspartate amino transaminase. इसी तरह जो नेगेटिव इंटरफेरेंस है दैट इज फॉर हेप्टोग्लोबिन एंड ट्रोपोनिन्स का डिपेंड करता है कि हम कौन सा एनालाइजर इस्तेमाल कर रहे हैं. लाइक रॉश के अंदर इसका जो सा रिजल्ट है और विट्रॉस के ऊपर वो डिफरेंट है कि रॉश वालों में ये डिक्रीज कर देता है और जो विट्रॉस एनालाइजर उसमें ये फॉल्स इंक्रीज कर देगा ड्यू टू हेमोलिसिस. देन हाउ टू डील विद हेमोलॉइड स्पेसिमेन, उसके अंदर ये है कि हम उसकी जो हमारा एनालाइजर है उसकी कट ऑफ को देखेंगे कि अगर हमारा जो मैन्युफैक्चर है अगर वो हमें कट ऑफ से कम वैल्यू है तो देन वी विल प्रोसीड टू टेस्टिंग. अगर हिल जो हेमोलिसिस इंडेक्स है अगर उसकी वैल्यू उस कट ऑफ से ज्यादा है देन वी विल गो फॉर डाइल्यूशन. अगर उसकी डाइल्यूशन नहीं हो सकती देन वी विल go for in vitro or in vivo hemolysis. अगर in vitro है तो then we will reject the specimen. अगर in vivo है then we will go for some alternative. So this is an algorithm how to deal with hemolyzed specimen. What causes a specimen to hemolyze? Then come the different types of causes. कि किसकी वजह से ये hemolysis cause हो रहा है. One of the cause is drawing of a blood from IV start or central line. And what is the percentage के IV start compared to venipuncture से कितना ज़्यादा hemolysis होता है? Then it is 2 to 5 times higher in IV start depending on the different studies. In one study there is 5.6% increase hemolysis versus venipuncture, and in another study there was 10.2% hemolysis versus 5.4% compared to venipuncture. Then there was a study. It is actually a meta-analysis, and it is clearly indicate that the straight needle venipuncture is superior to the IV start. The other common contributing factors to hemolysis includes prolonged tourniquet time, cleansing procedure with isopropyl alcohol needle placement, vigorous mixing of the tubes, and tube choice. The vigorous mixing of the tubes also lead to the rupturing of the RBCs, and it is one of the common cause which I have seen in our setup. and that after drawing of the blood by the phlebotomist and the nursing department, they will shake the specimen when they are transporting the specimen to the lab. There are other causes like prolonged anechoic time, cleansing procedures, as well as the needle placement. The benchmark for the hemolysis is the less than and equal to 2% hemolysis is acceptable by the lab, and it is given by the American Society of the Clinical Pathology. Then comes the second cause after the hemolysis is the clotted specimen. It is a very important cause because we are using the anticoagulants vials for the CBC and PT-APTT examination. And I have seen that, and it is a common practice in many setups that phlebotomists draw the blood and they just put it into the vial and place it into the rack and then transport the specimen to the lab. So, but there is a need of education on the tube inversion as well as the proper usage of the percutaneous. The other third one cause is the quantity not sufficient. It is a very important factor, especially in neonates and in NICU department. So the recommendations for the drawing of the blood at the NICU department is that the drawing of the blood should be less than 3% of the total body volume patient. If the age of the patient is less than 2 months, it becomes 9 ml per day in 7-pound infant. And it should be less than 10% of the total body volume if the patient age is more than 2 months, and it becomes 150 ml per day for the healthy adult. When we are drawing the blood, we have to educate our phlebotomist as well as nursing department regarding the dead volume of the instrument. We don't require the specimen not for the analytes. We require the volume the specimen for the as a dead volume as well as for the checking of the indices for the specimen integrity. To reduce this type of error among the NICU patients as well as in other patients, we can provide a list of commonly ordered tests and the minimum volume required so the testing can be prioritized. Then comes a type of error in which we will draw the blood from the line as well as from the central venous line or arterial line. So there are different issues can be arise in the sample which are collected from these lines. They can be hemolysis, dilutions, or drug contamination, and they will affect the results of different analytes like glucose, lipids, potassium, and magnesium. Why we draw the blood from these lines? Because it is very convenient and it will reduce the burden on the staff, and there will be a timely drawing of the blood. But there is more chances of the contamination of the specimen which we draw from these IV fluids, IV fluid lines. So we have to be very vigilant when the phlebotomist staff or the nursing staff drawing the blood from these lines. And there are a number of analytes which are affected from these contaminated line draws, like there is elevation of the glucose, magnesium, phosphorus, calcium, potassium, sodium, and chloride, and for the decreased creatinine, potassium, sodium, and hemoglobin. There is also some type of error in the total parenteral nutrition contamination because it has a huge content of glucose, sodium, potassium, and vitamins, minerals, and amino acids. So it will adversely affect the results of these parameters if the specimen is contaminated by the TPN. Then come an important type of error which occurred through the order of draw when we don't follow the order of draw. Then come the European Federation for Clinical Chemistry Pre-Analytical Phase Working Group. They have published an opinion paper in 2017 in which they describe the different problems with incorrect order of draw. There is hypernatremia due to sodium citrate or sodium EDTA contamination, hyperkalemia due to K-EDTA contamination, hypocalcemia, low magnesium, zinc, iron, or ALP due to K-EDTA contamination, poor coagulation due to transfer of anticoagulants, blood activated transfer interfering with coagulation tests, and dilution effects from pouring one sample into another. According to this opinion paper, there are three potential mechanisms of anticoagulant contamination: by the tract transfer, by backflow during closed loop vacutainer collection, and contamination by stream needle transfer. The conclusion of this paper is that the order of draw is not important during the routine closed system venipuncture, but the contamination may occur during the stream transfer. Then come the different studies like Cornerstone was in 2012. It will conduct an experiment in which there is a drawing of blood by different tubes, serum tubes, EDTA tube, and serum tube, and they measure the EDTA, potassium, calcium, magnesium, different parameters in first and third serum tube, and there is EDTA levels are less than 0.2 millimole per liter in all serum samples, and there is no difference in mean potassium, calcium, magnesium, ALP, or creatinine between first and third serum tubes. Similarly, another study is conducted in 2014, and they use two types of the tube like citrate, lithium heparin, and citrate, and in phase 2 they use serum clot activator, citrate, K, EDT, and citrate. When they are evaluate their result, there is very small, less than 1 second difference in APTT, and no statistically significant difference in PT, regardless of the collected first tube, second tube, after clot activator, or after EDTA. So the conclusion is that the evidence suggests that the KEDTA contamination does not occur during closed draws with plastic tubes, and one study which is conducted at UK hospital, the KEDTA contamination is seen in 2 to 15% of the specimen with abnormal potassium, calcium, magnesium, or zinc. So it is assumed that the contamination happened when strings are used for the sample drawing. Then come the inappropriate laboratory test requisition, and they vary from 11 to 70% for general biochemistry and hematology tests, and 5% to 95% for urine screens and microbiology, and 17 to 55% for cardiac enzymes and thyroid tests. Then come the quality indicators. According to ISO 15189, the quality indicator is important to monitor and evaluate the performance through the critical aspects of the pre-examination, examination, and post-examination processes. And when we implement a quality management system in our lab, then quality indicators are the crucial part of this quality management system. And irrespective of quality indicator, there is a way of identification and control of non-conformities, continual improvement, and internal audit. The mandatory quality indicators of pre-analytical phase which is suggested by IFCC, WG, LEPC as group, that different quality indicators are related to different steps of the pre-analytical phase, like patient identification have different quality indicators, data entry of the request have different QI, sample identification, sample collection, storage, and transport of specimen, and suitability of the sample. Each and every step which occur in the pre-analytical phase have different quality indicators which is specifically related to that phase or steps in process. Then come the recording of the laboratory errors. It should be a robust, continuous mechanism of error collection must be established. So the standardization of process is important to ensure the accuracy of the recording mechanism as well as to enable the effective soft training. कि हमारा कौन सा जो फेज है या कौन सी हमारा जो डिपार्टमेंट है वो पीक है, ताकि हम उसकी ट्रेनिंग कर सकें, रीट्रेनिंग कर सकें, ताकि हम एरर्स को उस जगह पे कम से कम कर सकें, या उस डिपार्टमेंट में, फिलबॉटमी में, या नर्सिंग में, या इनडोर या आउटडोर कौन सी जगह पे हमारे जो एरर्स हैं वो ज्यादा होंगे. The recording of laboratory errors can be done through different ways, like audits. We can plan audits. Second one is the manual recording process. Third is the incident reporting, and fourth one by the usage of laboratory information management system. According to ISO 15189, the audits can be used to collect the information on the relative rates of errors. The audit of the pre-analytical phase can be done by auditing of the request form, by audit of the specimen, and by audit of the booking in process. But there are limitations of these audits because it is a retrospective process, and audit does not provide the real-time assessment of rates of error incidents, and audit does not immediately alert users to the quality issues with their request. Then comes the manual recording process, in which we use a report formats at workstations to record errors. And this process is also a labor intensive compared with automated system of error identification in terms of both error recording and especially in reviewing data, and as such reach lower levels of compliance and underreporting of the errors. The another way of recording of error is the incident reporting, and it can be done by using the special software for risk management like Datix, and it should be a part of any healthcare provider's clinical governance process. The last one is the laboratory information management system, which is used by many different labs, and we are also using at our own setup. It is used to record receipt of specimen and reporting of the results, and it has potential to be used to record quality errors, report them to the user, act as repositories of error data, and also gather data on error rates. The advantage of using LIMS for error recording is that it is both prospective and as well as it is a retrospective, and it is very easy to review data in a simple and effective ways. And LIMS also has the report attributes, and it also fulfills the criteria by the ISO 15189. And according to that, the report should contain the comments on sample quality that might compromise the examination results, and comments regarding the sample suitability with respect to acceptance and rejection criteria. And this report attribute, which is laid down by the ISO 15189, is easily fulfilled by the laboratory information management system. Usage of report comments fields to record quality failures and highlight them in the report is very easy for the technologist. कि आप बैठे हैं सैंपल रिसीव की और वहाँ पे आप डिफरेंट कोड्स जो उनसे हैं उनको आप एडवाइस कर सकते हैं अपनी लैब के अंदर, और उसको एक सिस्टमेटिकली आप डाटा गैदर कर सकते हैं फॉर हेमोलिसिस पूरी लैब के अंदर या डिफरेंट डिपार्टमेंट्स के अंदर वी कैन यूज अ स्टैंडर्ड कोड लाइक हीम फॉर सैंपल्स दैट कैन नॉट बी एनालाइज्ड ड्यू टू हेमोलिसिस. तो डाटा रिट्रीवल इज वेरी इजी, और इस तरह हमें एक स्टैंडर्डाइज किस्म का डाटा जो सा होगा वो अवेलेबल होगा. Then come the data review. हम डाटा को किस तरह रिव्यू कर सकते हैं. There are number of quality management tools which can be utilized in the investigation of laboratory quality errors, and they can be reviewed by benchmarking. उसके अंदर हम किसी और लैब से या किसी और इंटरनेशनल जो डाटा है या बेंचमार्क है उससे कंपेयर कर सकते हैं. जैसे कि मैंने पहले बताया था कि हेमोलिसिस के लिए जो ASCP का बेंचमार्क है that is less than 2%. Then we can review the data by statistical process control. Yeah, similarly, in the same way that the laboratory reviews the quality control data for outliers, and error rates can be compared against the target mean and SD to identify the statistically significant changes. Then comes the third way of data analysis is by failure mode and effective analysis. FMEA, and it requires the knowledge of the steps involved in the testing process, target areas of high risk, and looks at method of adapting process to reduce failures. And the fourth one is the Pareto analysis, is actually a diagram which organizes the elements in order of frequency of occurrence, enabling the laboratory to target areas of high risk, and errors can be grouped by error type or location. So there are different ways in which we can analyze our quality error data. By benchmarking, by statistical, मतलब ये हमारी अपनी choice है कि हम अपने data को कैसे analyze करें. So the conclusion of this presentation is that the hemolysis and the clotted specimen is the number one and number two variable, which we will consider in the hospital inpatient practice, especially in our emergency department and in our ICUs and in our NICU departments. The clotting can be easily, specimen rejection can be easily solved by educating our laboratory and our phlebotomy as well as our the nursing staff. क्योंकि उन्हें ड्राइंग ऑफ स्पेसिमेन जो सा है वो तो ठीक है, लेकिन उनकी एजुकेशन की जरूरत है कि वो जैसे उसको शेक करना है या उसको इन्वर्जन जो सी है वो प्रॉपर करनी. तो insufficient sample volume or incorrect order of draw is a unique and sporadic cause of contamination for swing draws. तो जो पहले हमारा आइडिया था जी के ऑर्डर ऑफ ड्रॉ जो सा इट इज वेरी इंपॉर्टेंट एस्पेक्ट ऑफ रिजेक्शन, तो वो अब डिफरेंट स्टडीज जो मैंने आपको बताई है कि प्रीवियसली के जो आईएफसीसी वर्किंग ग्रुप है और उसके अलावा भी 2-3 स्टडीज ऐसी हुई कि जो क्लोज सिस्टम है उसके अंदर ऐसा चांसेस ऑफ एरर ड्यू टू इनकरेक्ट ऑर्डर ऑफ ड्रॉ जो है वो बहुत मिनिमम है। सिर्फ सिरिंजेस के अंदर जो कि यूके के अंदर एक स्टडी हुई थी उसके अंदर ये चांसेस जो हैं वो है, लेकिन इट इज अ स्पोरेडिक कॉज। तो दिस इज द कंक्लूजन एंड देन द लास्ट वन इज द एरर प्रिवेंशन। इसके अंदर हम ये है कि फिलबॉटमिस्ट की जो है वो एजुकेशन कर सकते हैं जहाँ पे फिलबॉटमी स्टाफ अवेलेबल है। इसके अलावा जहाँ पे फिलबॉटमी स्टाफ अगर अवेलेबल नहीं है तो हम नर्सिंग स्टाफ की जो सी है वो एजुकेशन करें मैक्सिमम। और जो छोटी छोटी चीजें हैं कि फॉर एग्जांपल क्लॉटेड स्पेसिमेन के लिए आपने उनकी जो फाइल है उसके अंदर एक लेवल तक जो सा है वो ब्लड ड्रॉ करना है, फिर उसके आपने उसकी ट्यूब की इन्वर्जन करनी है, ठीक है। तो एजुकेशन ऑफ द स्टाफ इज द मोस्ट इम्पॉर्टेंट थिंग के जो हमने इम्प्लीमेंट करनी है। देन देयर विल बी कंटिन्यूइंग एजुकेशन एंड देन विल बी द फिलबॉटमी स्टाफिंग। So these are the three main ways in which we can prevent these pre-analytical errors. And thank you. This is my presentation, and if you have any question, you can ask me. Thank you.
Thank you, Dr. Zubair, for your very comprehensive talk. Our next speaker does not need any introduction. Dr. Aamir Aijaz is the mentor and teacher of so many of us chemical pathologists. And he's ex-president of Pakistan Society of Chemical Pathologists. He has over 120 publications to his name. And he's also convener of the Chemical Pathology Committee at CPSP. He's currently working as Professor of Chemical Pathology at Muhyiddin Islamic Medical University, Mirpur. And he's going to talk to us about rational use of laboratory tests in critical care setup. Dr. Aamir Aijaz.
Assalamu alaikum. In the diagnostic procedures. So this is the background of my talk. This is my disclaimer that I have no financial relationship or any financial interest. And I have, of course, so there are many tests which can be rationalized, but I have selected 4 group of tests. One is the thyroid function test, lipid profile, test for stress hyperglycemia, and blood gases and are those which we come to my clinical practice. First, a 42-year-old male admitted in a COVID-19 isolation ward. His thyroid profile was as following. T3 was low. Assalamu alaikum. First of all, I want to thank Indus Hospital and Healthcare Network to provide me this opportunity to talk on this August meeting and August audience. The topic I have selected for the talk is rational diagnostics in critical care. Why I have chosen this topic? Because as you know, Indus Hospital is doing a wonderful job to provide free of cost healthcare to his patients, and there is no cash counter in this hospital. It is absolutely free for all the patients and for all the procedures. Now, when you are providing such a nice facility without any charges, the things should be very rational. The medicines should be given only when they are required, and the tests should only be advised and carried out when they are required, and only those tests should be done which are absolutely necessary. And then, secondly, the test should be done in a way where it can be of maximum use. So, what we call it, there should be rationale in the diagnostic procedures. So this is the background of my talk. This is my disclaimer that I have no financial relationship or any financial interest. And I have, of course, so there are many tests which can be rationalized, but I have selected four group of tests. One is the thyroid function test, lipid profile, test for stress hyperglycemia, and blood gases and electrolytes. And we will discuss these four topics. And I will try to make this presentation as interactive as possible. So for each group of tests, I have selected one patient. Nearly these patients are those which we come to my clinical practice. First, a 42-year-old male admitted in a COVID-19 isolation ward. His thyroid profile was as following. T3 was low, T4 was normal, and serum TSH was also normal. So what is your diagnosis? I invite my junior colleagues or students who are sitting in and listening to this talk. They may participate in this quiz. So I give 10 seconds. You can write your answer in the chat, or you can write it with yourself on a paper and pencil. That will simply increase your participation in the talk. So please go on writing your answers. What is your diagnosis in this patient who is admitted in a COVID ward and has only T3 low, and the other two are normal? Yes, most of you probably have given good answers. It is non-thyroidal illness syndrome, which is also called sick thyroid syndrome. Non-thyroidal illness syndrome, or NTI, was previously called sick thyroid syndrome. It is characterized by low T3 normal or low TSH and or low T4. It is a protective response of body in chronic illness to reduce metabolism. Low T3 is common in critical illness. And what is the mechanism of it? Actually, this Ndi syndrome is a protective response in critically ill patients. You know that normally T4 is converted to T3 and reverse T3. Most of it is converted into reverse T3. Only some of it is converted to T3, which is the active hormone. When there is illness and body wants to protect, reduce the metabolism, the conversion of T4 to T3 is reduced. Instead, reverse T3 is increased. And you know, reverse T is an inactive hormone. So that's why there is decrease in T3 in critically ill patients. And how it happens, not exactly known, but most probably it is due to some interleukin factors or those cytokines which are released during inflammation, and they inhibit the enzyme which converts T4 to T3. This is another very useful diagram to understand this mechanism of Ndi syndrome. You see, first of all, there is an increase in reverse T3 and decrease in T3. Increase in reverse T3 and decrease in T3. Then there is a decrease in TSH. As the illness increases, patient becomes sicker. There is also a decrease in TSH. And finally, when the patient becomes very sick, T4 also, free T4 is also decreased. Thyroid function in Ndi syndrome should not be assessed in critically ill patients. Thyroid function should not be assessed in critically ill patients unless there is a strong suspicion of thyroid dysfunction. If you suspect thyroid functions, thyroid dysfunction in a critically ill patient, then TSH may be accompanied by T4. How to manage Ndi syndrome? There is some controversy in starting thyroxine in these patients. Majority of authors recommend that critically ill patients with low serum T3 and low T4 should not be treated with thyroid hormone because it is a protective phenomena. There are some authors who say you may give some thyroxine, but mostly people are against it. The condition subsides with general improvement of the patient. Now we come to the second part. A 75 years old man admitted in high dependency unit for the management of COVID-19 and its complications. His condition is deteriorating. His lab investigation results showed RT-PCR positive, HSCRP 110, procalcitonin 1.4, which is raised. CRP is also raised. Ferritin is also markedly raised. Now, lipid profile was advised in this. Why? I don't know. There was a trend initially to advise lipid profile in COVID-19 patients. I asked many physicians why they advise lipid profile, but I couldn't find any satisfactory answer. Now, you can see total cholesterol was normal, triglyceride was raised, LDLC was normal, and HDLC was also normal. So, is lipid profile indicated in this patient? No. I give the answer straight away that the lipid profile is of no use in such situations. Why? Let's see. Lipid profile in critically ill patients is not indicated because during critical illness, triglyceride and cholesterol may change significantly without any metabolic cause. And triglyceride is strongly affected by cortisol. The stress hormone and rises. So similarly, LDL cholesterol has also been shown to be affected by stress. Total cholesterol may decrease in sepsis, cardiovascular, and cancer patients, while increase in CNS and renal disease disorders. So this slide summarizes the effects of critical illness on lipid profile. You can see total cholesterol is decreased up to 47%, maybe decrease up to 47%, LDL may be decreased up to 40% nearly, and HDL is decreased up to 11%, while triglyceride may be increased up to 50%. So triglyceride increase and all the cholesterol fractions they are decreased. We also carried out a study at when I was working at Armed Forces Institute of Pathology and the study, the paper has been accepted at PFMJ, and our results were also similar, that in various conditions you can see variable changes in triglyceride and various fractions of cholesterol were found. So what is the mechanism of lipid modifications in critically ill patients? First of all, it is an acute phase response that body protects, diverts its functions towards a more useful things which can be used in stress rather than less useful things. Then there are adrenergic mediated adipocytes lipolysis, and that lipolysis results in increase in triglycerides. Drug use during hospitalization also may produce such things. The reduction of saturated fat intake and lifestyle changes can also produce these changes. What happens in ACS, acute coronary syndrome? It is particularly important. Lipid profile is quite important in ACS, and it's a very important question that should we do lipid profile and what we should do when we find some results on lipid profile. There are phasic changes in lipid profile, lipoprotein levels falling, and ACS. So these measurements may not be reliable. So without the metabolic itself abnormality, the changes may be due to some other factors. Difficult to find patients' baseline lipid profile correctly. As the changes are minimal in the first 24 hours, lipids should be evaluated in this. So if you at all want to do get some idea of the baseline of the lipid profile, please do it in the first 24 hours, because during first 24 hours it has been shown by various studies that the changes on the lipids are minimal. So lipid profile should not be used for ruling out. This is very important. In our country, I have seen that I'm not talking of cardiologists or senior physicians, but many doctors, they advise lipid profile as a diagnostic test for ACS. They think that if a patient has got hypercholesterolemia, so he has got ACS. No. Lipid profile is not a diagnostic test for any cardiac condition. It is lipid profile. They are very important coronary risk factors, but they are not diagnostic tests for MI. So what is a smart approach for measuring lipids in coronary artery disease? The answer to the $1 million question of whether lipid profile should be done in ACS or not. This is a very nice approach, and I want to share with you that total cholesterol, LDL, and HDL should be measured following ACS. If the resultant values are in higher range, requiring an intervention intervention, for example, statin therapy, the baseline values will make the intervention more necessary. So if the values are high, then you may start statin. If the values are low, these should be repeated for many weeks after the recovery, as these may be falsely low. So don't believe the low values, but if the values are high, then you can start the statin therapy. And please do it in first 24 hours. And if you have missed those 24 hours, then it is better not to do it. Then comes the next patient or next part of our talk, and these are about the stress hyperglycemia. A 57-year-old woman has been admitted in an ICU for CVA. She is not a non-patient of diabetes mellitus, but her capillary glucose checked on glucometer shows glucose level very high, 231 milligram, and HbA1c was normal. Can you name hyperglycemia in this patient? Should be monitored by A1C or glucometer. So what is this? What is the type of hyperglycemia and how it should be monitored? These are the two questions. And again, for 10 seconds, you may write your answers on the piece of paper or in the chat box. Why there is patient is not a non-diabetic and her glucose is high, but A1C is less. Yes, it is stress hyperglycemia. So if the patient was an undiagnosed there could be a possibility that the patient was an undiagnosed diabetic, but then HbA1c was normal. So that this thing is ruled out, that she's not a case of undiagnosed diabetes mellitus. She's simply a case of stress hypoglycemia. This is very common in ICUs and in critical ill patients, HDUs, etc. Stress hypoglycemia is a very important condition. This test can be physical, that this can be mental, and you can also find in patients roaming about. And it's how it should be monitored. It should be monitored by glucometer. You cannot do A1C because A1C gives previous 3 months results. So A1C is of no use in such patients. Stress-induced hypoglycemia is an exceedingly common finding in patients admitted in critical care units. Random plasma glucose concentration of more than 7.8 or 140 milligram per deciliter in the hospital setting in first 24 to 48 hours after admission. This is defined as the stress hypoglycemia. Hypoglycemia in the setting of critical illness results from raised levels of counter-regulate. Why it happens? Because of stress-related hormones, which are counter-regulatory hormones to insulin, and they increase the glucose levels. Exogenous factors such as parenteral or enteral nutrition, etc., they also aggravate hypoglycemia. Now, a million-dollar question. Million-dollar question is, should we treat stress hypoglycemia? And if treat, how to treat it and why to treat it? Yes, it should be treated to avoid sepsis. If you will not treat hypoglycemia, it is a very important predisposing factor for the stress. And what should be the target? This target for glucose management in critically ill has been a subject of long discussion. Ultimately, a very large study, which is known as Nice Sugar Study, which was published in New England Journal of Medicine in 2006 or 7, and this finally decided that the values should not be very low, and it should be between 140 to 180 milligram, or roughly between 8 to 10 millimole per liter. So in such cases, you should give insulin or whatever treatment required, and the level should be maintained between 140 to 180 milligram per deciliter. It is again once very important that the level should not be very low. Previously, the level was 110, recommended level was 100 and 110, but now it has been increased to avoid hypoglycemia, because hypoglycemia is known to be a very serious thing in critically ill patients. Hypoglycemia in an ambulatory patient may not be that serious, because in ambulatory patients, the hypoglycemia may cause some drowsiness, etc., because of the neuroglycopenia. While in critically ill patients, there may be some cardiac factors also, and that may lead to arrhythmia. So that's why, to avoid arrhythmias and sudden deaths, hypoglycemia should be avoided in critically ill patients. Now, the second question was whether to monitor this by pillary blood glucose, that is glucometer, or by laboratory venous blood glucose. Our study, we carried out a study, and we found that there is an excellent correlation between the capillary blood glucose and laboratory venous blood in critically ill patients. And paper is also under publication, and we can confidently say that glucometer is a good strategy for use in critically ill patients, and we should not advise A1C. So in this particular part, I must say that POCT is a superior thing than the laboratory derived tests, and the rationale of doing A1C is very low. So it can be misleading and it should not be used. And POCT may be verified periodically by LDT, for example, plasma glucose levels. The last part is in a 55 years old Female presented with persistent vomiting, severe breathlessness, and moderate renal failure. Her biochemical test showed pH was high, alkaline, PO2 was normal, PCO2 was low, and bicarbonate was low. Potassium, sodium was normal, potassium was high, chloride was normal, and anion gap was high. So what is the most probable acid-base disorder? Can we diagnose this disorder with simultaneous blood gas and electrolyte analysis? 10 seconds, and you may write your answers on the chat box or with your paper and pencil. So here you can see that the pH is high, that is alkalosis, PCO2 is low, that is respiratory alkalosis, bicarbonate is low, that is metabolic acidosis, and anion gap is high, which is again a metabolic acidosis. So yes, it is a triple disorder, which means there is respiratory alkalosis, metabolic acidosis, because anion gap is high. So, but the anion gap is high, and bicarbonate is not that low. This indicates the presence of a simultaneous metabolic alkalosis also. So this is a triple disorder, and we cannot diagnose triple disorders without simultaneous measurement of blood gases and electrolyte analysis. So that's why our next passage is that blood gas analysis is one of the most important and common investigation in critically ill patients. The new instruments offer simultaneous estimation of blood gases and electrolytes. Blood gases include pH, PO2, PCO2, and bicarbonates. Electrolytes include sodium, potassium, and chloride. And you then the instruments are available now, which can measure all these parameters in one go, and they also give you anion gap, and then you can determine whether the patient is in double disorders or triple disorders. The purpose of making these instruments was the same, because in now people want to do the simultaneous analysis to give a complete diagnosis, biochemical diagnosis in the patient. These tests can be done on arterial, venous, or capillary. There is no now compulsion that it should be arterial. You can do venous, you can use venous blood, and you can also use capillary blood. Cartridge-based equipment are also available for low turnover. If your lab is small, you can use a cartridge-based instrument, and if your workload is high, you can use a wet instrument like Cobus 221. Why simultaneous analysis? Calculation of delta ratio. You can calculate delta ratio. The delta ratio is used for the determination of a mixed acid disorder in an elevated anion gap metabolic acidosis. So this is the formula of anion gap of delta ratio. This is the formula of delta ratio. Measured anion gap minus normal anion gap, normal bicarbonate minus measured bicarbonate. Okay, and for biochemical students, the students of chemical pathology, anesthesia, medicine, PEDS, this is very useful parameter, and you can diagnose acid-base disorders quite perfectly by using these disorders. This is my final slide. I'll now conclude by saying that there are 5 don'ts and 5 do's in today's talk. Don'ts are thyroid function tests should not be advised until very strongly indicated to rule out conditions like myxedema. Non-thyroid illness should not be treated with thyroxine. Non-thyroidal illness should not be treated with thyroxine. Lipid profile is not a diagnostic test for myocardial infarction. Please remember, it is not a diagnostic test, but can be used for early start of lipid lowering therapies if found abnormal. Do's. In critically ill patients, glucose estimation by POCT should be done in first 24 hours of admission to rule out stress hyperglycemia. Simultaneous estimation of blood gases and electrolytes can be immensely helpful in critically ill patients. I thank you all for your patient listening, and this was all from my side. Thank you very much.
Thank you, Dr. Aamir, for your wonderful talk as usual. Our next speaker is Dr. Adnan Zubairi. He also does not need any introduction. Dr. Adnan has over 30 years of experience in pathology in general and chemical pathology in particular. And we are lucky that he has joined Indus Health Network as Director, Clinical Laboratories Outreach since March 2021. Dr. Adnan will be talking about the roles and challenges of point-of-care testing in critical care. Dr. Adnan.
Starting my presentation, I would like to thank the organizing committee of ICON 2022 for giving me the opportunity to talk on a very important topic, which is very important in the emergency department for better patient care and early disposal of the patients in the heavy emergency departments. I have no conflicts of interest or commercial bias to disclose. Point of care testing is simply the medical testing which is being performed at the site of patient care instead of being done in the conventional laboratory, with the implication that the appropriate clinical decisions are made there and then, leading to improved health outcomes. In tertiary care settings, it is very important in heavy emergency departments that the patient disposal should be done in a rapid manner and to get the better clinical outcomes. In this regard, the point of care testing is required in all the emergency departments. And I'll talk about it in the later, the advantages of the point of care testing. And the point of care testing programs, they are also useful in operating rooms, critical care units, and the conventional wards as well. These are the few devices of point of care testing which are commonly used in clinical practice. The most common is being the glucometers, which comprises more than 50% of the global point of care testing market. And the other devices are like arterial blood gases devices, and the devices on which the chemical analysis, coagulation analysis, and the infectious disease analysis are being done. In COVID-19 pandemic, the manufacturers of point of care testing devices, they had a challenge to develop the devices to meet this challenge and to get the point of care testing facility made available for the diagnosis, screening, and monitoring of COVID-19 patients. This is one of the testing device for rapid COVID-19 antigen testing. In this device, the samples are being poured in the well and they travel laterally. The antigen antibody complexes are being formed and they are being visually observed. The control line is there to see the validity of these devices, and the test line is important. Its presence indicate the positivity of the COVID-19 antigen, and the absence of line at test area indicate that there is no COVID antigen present in the sample material being tested. Nucleic acid amplification tests are typically classified in two major type of amplifications. One is the conventional PCR and the other one is the isothermal amplification. In traditional PCR, it requires a cumbersome lab equipment to cycle samples through different temperatures for denaturing and amplifications of DNA and RNA, which inherently limits its use in point of care settings. Isothermal amplification were developed using enzymatic mediated denaturation, avoiding the need of repeated thermocycling. Loop mediated amplification, which is a type of isothermal amplification, was used to develop a highly sensitive and specific COVID-19 assay, enabling as easy to read bedside results in under 1 hour. These are the instruments and devices for rapid PCR in which the nasal swab is being placed into the device and the amplification is being done and the results are made available in around 5 minutes time. These sort of devices and instrumentations are very useful in emergency departments to screen the patient for COVID positivity or negativity. And these devices are also being used at the departure and arrival terminals of the international airports as well. So as far as the diagnostic options for COVID-19 are concerned, we have got the lab testing, the lateral flow immunoassay, which I have already told you, and the molecular assays. In the conventional lab testing, the turnaround time is approximately 12 to 24 hours, in which the sample is being transported to the laboratory where the RT-PCR is being performed and the results are conveyed to the treating physician. It is very high sensitive and specific. Whereas as I mentioned that the lateral flow immunoassay, the tests are being made available in around 15 minutes time. It is less sensitive and specific, meaning thereby that there are chances of false positive as well as false negative. And in rapid molecular assays, the nasal swab is put into the buffer solution and the staff familiar with the process runs the molecular test and the results are made available to the treating physician in approximately 30 to 60 minutes. There are some differences in the point of care testing and the conventional laboratory based testing. The red highlighted steps are being minimized in the point of care testing, which enables the rapid turnaround time and the easy availability of the test result in minimal period of time. The required features for point of care testing devices are that the devices should be simple to use and the reagent and consumable must be robust. It should not be temperature sensitive and the results from the POCT devices should be concordant with the established laboratory methods, meaning thereby that a sample being taken at the same time sent to the conventional laboratory and tested on the point of care testing devices, there should be concordance of the result between the two methods. The devices together with the associated reagent and consumer must be easy to use, safe to use, and must have a very simple disposal. The WHO has devised a criteria for the development of point of care devices, and the criteria is called the assured criteria. Assured criteria means that it should be affordable, it should be cost effective to the end user, it should be sensitive with minimal of false negative, it should be specific with minimal of false positives, and it should be user friendly, meaning thereby that there should be minimal steps to carry out the test. It should be rapid and robust, so the turnaround time should be shortened and there should be no need for refrigerated storage of the material. Equipment free, meaning thereby that no sophisticated or complex equipment is required, instrumentations are required for the testing, and it should be easily delivered to the end user. The potential advantages of point of care testing include that the turnaround time is reduced by minimizing the steps which are mandatory for the conventional laboratory, and there is improved patient management. There is an interaction between the patient and caregiver while the test is being performed on the point of care device, and the results are being communicated there and then to the patient for better healthcare and immediate clinical decisions. And there is improved patient morbidity and mortality rates. If a patient sample is being sent to the lab to get a result of potassium in half an hour or 40 minutes, we can get the result in less than 2 minutes on point of care testing device, and the patient can be managed so the morbidity and mortality can be reduced. And there is reduction in the administrative work associated with the test requisitions and reporting. And there is reduced risk of errors. There are minimal pre-analytical errors. For example, the wrong selection of wrong anticoagulant tube, sample collection tube, or the inappropriate volumes in the sample collection tube. Whereas in point of care testing, it is finger prick and the device. So the errors are minimal, and there is reduction in the hospital admission. We don't admit the patient just for the to establish the diagnosis, and the diagnoses are being made in the emergency department. And finally, there is improved overall cost of care. The disadvantages of the point of care testing include the administrative work associated with the training and certification of the operators. Caregivers are required to perform tests. Increased risk of error if tests performed by the untrained operators. These are the potential disadvantages of the point of care testing. As far as the classification of types of point of care testing instrument devices, there are basically the three types of instrumentation. One is the small handled single use point of care testing devices, and the second one are the same devices with the monitoring device, and the third one is the large cartridge based benchtop POCT devices. And these are the analytes which can be tested through these analytical principles on these devices. The market of the point of care testing globally is increasing exponentially, and it was $29 billion in 2020, which is expected to increase up to $50 billion by 2025. So it is a rapidly growing device modality for the diagnosis in healthcare. Now, coming to the challenges of point of care testing, there are many challenges, which includes the regulations, the documentation, the managing the users, the quality control, results correlation, and then the device management and the user proficiency. The College of American Pathologists had a survey, had regular surveys of the medical facilities in which they have found out the most commonly cited deficiencies in point of care testing programs, and the most common among them is the competency, followed by the activity menu and document control and others. As far as the standards and guidelines for the point of care testing are concerned, apart from Joint Commission International, there are College of American Pathologists guidelines, and there is a specific ISO standard, ISO 22870. To meet the regulatory requirement, the management requirements are to be fulfilled. These management requirements include the development of quality management system and the trainings of the staff, and acquiring the qualified personnel for their job. And then there is a need of quality control plan, and to meet the regulatory requirement, the training and competency of the staff and the users is required to be made. Then there is a requirement of validation of devices and methods, and all these things need to be documented. So the challenge comes when we point out that the point of care testing requirement ISO 1522870, the management and the other people, the other stakeholders, they would say, what is the need of this standard? We are already ISO 9001 or 15189 certified, and we know the quality management better. So there'll be financial burden and it would be cumbersome. So there is no need for ISO 22870 or any other regulatory requirement. And the clause 5.1.2 of this standard, it states that the lab director shall be responsible for procuring, evaluating, and selecting all POCT quality control, establishing documented quality policy and protocols for performance of all point of care testing associated quality control and quality assurance. This is proficiency testing and inter-instrument comparison of arterial blood gases, in which the three type of material are being sent by the College of American Pathologists, which the testing is performed on the instrument, and the three instruments and the results are being compared with the peers using the same instrument. Moreover, there is inter-instrument comparison as well, in which the instrument 1 and 2 and the instrument 1 and 3 and the instrument 2 or 3 can be compared. And this is again external quality assurance program for glucometers, in which we can see the three different concentration materials are being tested on multiple devices, and the results are being reflected in this dot plot. So the next challenge is the training and competency of the staff and users. The appropriate theoretical and practical training program for all POCT personnel must be conducted, and the POCT operator performance shall be monitored, and record of these trainings and their performance should be recorded. And the training contents must include the sample collection, clinical utility and limitations, analytical procedures, reagent storage, quality control and quality assurance, technical limitation of the devices, responses to the result that fall outside the predefined limits, infection control practices, and the correct documentation and maintenance of results. These are the 6 elements of competence assessment. First is the direct observation of routine patient test performance. Second is the monitoring of recording and reporting of test result. Third is the review of test results, QC records, proficiency testing results, and maintenance record. Fourth is the direct observation of instrument maintenance and functional checks. Fifth is the assessment of previously analyzed specimens, internal blind testing samples, and external proficiency testing samples. And sixth is the evaluation of problem-solving skills. These are the different documentation which are required for the point of care testing programs. Next important challenge is the IT integration and data management. The result interfacing and the Bismillah ar-Rahman ar-Rahim.
Thank you, Dr. Adnan. The presentation stopped abruptly. I don't know what was the problem, but I think you had almost reached the end. So if there are any queries, we'll take it up in the end. It was an excellent talk, as usual. Okay, so our last speaker for the session is Dr. Sama Muhtar, our ever vibrant emergency room consultant. She has led the emergency department at the front line during the pandemic. Her main interests are medical education, research, and capacity building of the ED. And she will be talking about the ED's perspective on the role of laboratory in meeting the needs of critical care. Dr. Sama Muhtar.
Of the Emergency Medicine Department at the Indus Hospital and Health Network. I welcome you all to the ICON 2022. I've been invited to speak on the topic of the role of laboratory in meeting the needs of the critical care and emergency department perspective. So why are we talking about the emergency department? The emergency department suffers from quite a dilemma of overcrowding and prolonged ED stay. Here, as you can see, the emergency department, the doctors and the patients, there's quite an influx going on in the emergency department, especially that of the Indus Hospital, Pareto Crossing. So crowding is a frequent concern in the emergency department, and one way of addressing this problem is through point-of-care blood tests. Amongst all the procedures that we can utilize to reduce the overcrowding, the emergency department can also be facilitated through point-of-care tests. Assalamu alaikum. My name is Sama Muhtar. I'm a consultant of the Emergency Medicine Department at the Indus Hospital and Health Network. I welcome you all to the ICON 2022. I've been invited to speak on the topic of the role of laboratory in meeting the needs of the critical care and emergency department. And prolong ED stays, and these ultimately affect the patient outcomes. They result in increased lengths of stays and also increase the healthcare costs. Here, as you can see, the emergency department, the doctors and the patients, there's quite an influx going on in the emergency department, especially that of the Indus Hospital for Ranvi Crossing. So crowding is a frequent concern in the emergency department, and one way of addressing this problem is through point-of-care blood tests. Amongst all the procedures that we can utilize to reduce the overcrowding, the emergency department can also be facilitated through point-of-care testing with the aid of the laboratory department of the hospital. And this has been proposed to decrease patients' length of stays. The significance. Studies indicate that lab analysis accounts for approximately 43% of the data used for critical care clinicians to aid in decision-making. So the more rapid the clinical data available, the more rapid the clinical decisions, and hence effective ED patient turnaround time. What is the role of laboratory in the emergency department? The laboratory plays a pivotal role in supplementing the ED in meeting the needs of a high volume, low resource setting, just like the Indus Hospital Health Network Emergency Department. And this collaboration improves upon clinical accuracy and effective clinical decision-making. Point-of-care lab testing undertaken near patient location results in rapidly available test results, rapid clinical decisions, and hence the patients are discharged or admitted or referred out on time, and hence newer patients can be taken up in the emergency department. So here I'm going to show you the study that was done in 2020. And this studied the impact of point-of-care testing on the length of stay of patients in the emergency department. And this was a cluster randomized control study. The point of showing this study here is the importance of point-of-care lab testing in aiding the process flow in the emergency department. So in this study, they had two arms. One was the interventional arm where we used point-of-care analyzers, and one was the traditional central laboratory. And the primary endpoint was ED length of stay, and secondary endpoint was the time to result. And of 23,231 patients that were included, 20,923 were analyzed for the main outcome measure. And they saw that the mean and standard deviation of the age was 46 plus minus 20 years, and 36 of them underwent blood sampling. And the mean standard deviation of the length of stay was 2 or 3 plus minus 161 minutes for those who had point-of-care testing, and 210 plus minus 168 minutes for those in the control arm that had the normal central laboratory mechanism of testing. So you had a length of stay reduction rather, of almost minus 9 minutes of those who received point-of-care testing, and in the control arm, it was minus 17 minutes. And the median plus minus the standard deviation for test result time was 28 plus minus 31 minutes, significantly less, with a p-value of less than 0.001 for those who had received point-of-care testing. So this study really tells you that the implementation of extended panel point-of-care testing solutions in the ED did not significantly reduce the length of stay, but it does reduce the time to result. So further studies, of course, are needed to analyze the effect on the length of stay, but we do know from this study that the time to results can be reduced. So there are 3 levels of lab parameters in the ED. The first being the urgent obligatory parameters, where the role of point-of-care testing really comes into play, resulting in immediate therapeutic decisions and must be available within 60 minutes of patient presentation. So that you can take rapid decisions. And then there are the obligatory parameters, as the name suggests, like diagnostic and therapeutic consequences in the ED, and emergency tests required for they require for process management and patient flow in the ED. So what we're really talking about here is the one on top, which is the urgent obligatory parameters, where the role of point of care testing really comes into play. So we noticed, since the world has been suffering from the pandemic, the lab along with the emergency have really collaborated in terms of the COVID-19 pandemic. And this collaboration has resulted in faster etiological diagnosis for COVID-19, better patient monitoring, and help in the surveillance as well. Point of care testing in critical care is one way of simplifying the lab analysis process so the lab data are more readily available to the clinicians. There's a close collaborative relationship, allows robust point of care testing to be implemented in the critical care areas like the emergency department, and reduced turnaround time, therapeutic time is a major advantage of point of care testing. The picture here depicts the point of care testing station at the emergency department of the Indus Hospital and Health Network, Karachi. So what is the patient's perspective? So far, we've talked about the hospital perspective, the doctor's perspective, but what is the patient's perspective? Patient intervention decision can be expedited because of this. This can potentially save lives and allow for rapid titration of medications, or for those patients who are mechanical ventilations. There is decreased intubation times and ICU length of stays, reduction in blood loss. So point of care testing requires 2 drops of blood for analysis, whereas a regular routine lab requires 3 ml of blood for analysis. And of course, the patients are discharged quicker. Here in this diagram, you can see that in this lower part, you can see that the patient has arrived. You have a sample collection with 2 drops of blood. You have a whole system that allows for a quick sampling and rapid results. The sample is loaded, the result is analyzed, and the patient is either admitted, discharged, referred out. So you're actually saving time and you're increasing your patient turnover time as well. The benefits: rapid and accurate results, it's cost effective, it helps in early clinical decision, decreased ED waiting times and length of stay, which is what we want in a low resource, high volume setup. And outcome studies, however, are needed to conduct it to assess the true impact of point of care testing on the care of critically ill patients. So what are the initiatives undertaken at the IHHN in collaboration with the laboratory? So far, we're doing point of care testing for coagulation profile, for troponins, blood gases, urine DRs, pregnancy test, amylase, CBC, your urea correct electrolytes, stat tests, gene experts, AFP gene experts, but there's so much more that we need to explore in collaboration with the laboratory. And what is the need of the hour? This brings us to the most crucial thing, that what we need right now to take this further is a new set of skills for critical care nurses, so they can be trained in this regard, knowledge of the lab regulatory issues. We need commitment to training and recertification where need be. We need quality improvement programs. We need effective data management, so we have our baseline data so that we can work on it and develop further protocols to help patients out. We need education of practitioners about this. We need conversion from lab measurements to appropriate in vivo and ex vivo measurements. And we need real-time utilization assessment to go further in this. So what is the goal without a plan? It's just a wish. So we do have goals for the future here at the emergency department, IHHN, along with the laboratory. We hope that in the future, there will be increased and fast track liaison between the lab and the emergency department. And we hope to develop a stat lab to meet the demanding needs of a low resource, high volume emergency department. These are my references. I'd like to thank you for your time and your patience. And if you have any questions, I'd be happy to answer. Please post your questions in the link below. Thank you.
Thank you, Dr. Sama. Thank you, Dr. Sama, for the wonderful talk. And I'm so sorry for the internet issues which you faced in the talk initially. So participants are requested to please write their questions in the chat, and also to fill up the feedback forms, because without the feedback forms, you will not be able to get the certificate. So let me start by asking Dr. Sama. Dr. Sama, you focused on POCT for your presentation, but what is your expectation of a reasonable turnaround time from the central lab?
Good afternoon, Dr. Fatima. Thank you for the opportunity to be here in this lovely ICON 2022. To this point, we've had a great collaboration with the laboratory at the Indus Hospital and Health Network, collaborating with the ED in terms of VOCT and stat labs, and I think we're going on the right track. However, considering international standards, we do expect that we can have a turnaround time of maximum of 60 minutes in certain critical cases. And I believe, and I can say for sure, that when we do have critically ill patients in which we need to take certain quick decisions, we've had good collaboration with the lab, and we're able to get the turnaround times at a lower level. However, further streamlining of that, I think in future, universally for emergency care patients would be beneficial.
Thank you. Thank you, Dr. Sama.
You're welcome.
Dr. Zubair, there's a question for you from one of our residents. Are the changes in the concentration of analytes same for in vitro and in vivo hemolysis, except for raised serum bilirubin in vivo hemolysis? And to add on, like, how would you differentiate between in vitro and in vivo hemolysis? What is the protocol for a repeatedly hemolyzed sample? How do you go about it? Dr. Zubair, are you online? Dr. Zubair? Dr. Adnan or Dr. Aamir, can you please answer that question for our residents? Dr. Aamir, please. So should I repeat the question, or were you able to get it? कौन है डॉक्टर सर हैं क्या? Dr. Aamir, are you there? I'm sorry for the internet glitches. Our speakers are unable to connect with us online for answering the questions. But
Dr. Amin, please repeat the question.
Okay. The question for Dr. Zubair is, how can we differentiate between in vitro and in vivo hemolysis, especially for, apart from bilirubin, how can we differentiate? Are the changes in the concentration of analytes same for in vitro and in vivo hemolysis, except for the raised serum bilirubin in vivo hemolysis? So would you like to answer? This is really disappointing. We're having internet issues, and we wanted to have a fruitful discussion at the end of the session. But perhaps you can write the discussion in the chat. Dr. Aamir is answering the replies, and so is Dr. Sama in the chat. So if you're unable to have an audio, we can continue with the chatting, and I will speak out the answers. Dr. Aamir says that qualitative POCT should be avoided for troponins. Yes, and my question to Dr. Adnan would also be that how would you balance the lower sensitivity of the POCTs with the benefit of faster turnaround time when we're talking about POCTs for troponins, for rapid tests, rapid antigens? All these tests, although they provide a quicker turnaround time, but they have compromised sensitivity. So if any of, if Dr. Adnan or Dr. Aamir can answer to that. Maybe in the chat box if you cannot connect to audio. Yes, please, Dr. Sama, go ahead.
Okay, I think your question is targeted toward the chemical pathologists, but I can give an ED perspective on it. I think despite the fact that a POCT might have less sensitivity, if you keep the clinical picture in mind of the patient, and if the labs, even if they are insensitive, they do give you some inclination of how you can help the patient and lead to a good a procedure or admission that is required for the patient. So as far as the ED perspective of the low sensitivity of POCT goes, I think we measure it and balance it against the clinical needs of the patient. And that does, it's better to have some result than to have no result at all.
So I think we come back to the point where Dr. Adnan said that adequate validations are absolutely necessary. So because there are a host of POCT tests out there, so we have to decide which test is best. And as Dr. Aamir said, qualitative tests should not be used. There should be at least quantitative with good lower limit sensitivity, as better sensitivity as you can get. You have to balance the pros and cons. So POCT is a whole world of diagnostics, and there are good options available in the market, and you have to balance them. You have to take a good quality, you have to choose a good quality POCT with all the points which Dr. Adnan mentioned about the connectivity, about the competencies, about the regulations, etc. And Dr. Aamir has replied to Dr. Aisha's question by saying that LDH would be high in vitro hemolysis. Anything else if you have any other queries? And I think in the chemical pathology chat group and in the trainees group, you can post your questions over there, because we have all our eminent teachers in the group. Dr. Zubair, Dr. Aamir, Dr. Adnan are all there. I'm there as well. So whatever unanswered questions are there, they can be posted there, and you will get all the answers. And we hope to provide you with the results. If there is anything else that you would like to ask over here, please do fill out the feedback forms, because it is absolutely mandatory for your certificates. Are there any other questions? And so the clinical team's perspective is there, that they need POCT for tests of high importance. Dr. Sama's input has been documented. Dr. Aamir, would you like to give another try to see if your internet is working? If you would like to give any expert opinion? I remember your famous one-line, two-line presentation regarding the qualitative POCT tests. Okay, I think if there are no more questions, we can end our session over here. I thank all the eminent speakers for their time. I'm really sorry for the final internet glitches which we had during these question answer sessions, and a little bit during Dr. Aamir and Dr. Sama's talk. But this was our first attempt at a virtual conference, and hopefully we'll be better at it next time. Thank you so much for all the to all the participants, and thank you to all the eminent speakers. Thank you, ICON 2022, for giving us this opportunity. Thank you on behalf of Indus. Thank you very much.